Hello everyone, and welcome to today's webinar, Trauma Verification's July Q&A Web Conference. I would now like to introduce Megan Hudgens, Trauma Verification Program Coordinator.
Hi everyone, Megan Hudgens here. Thank you so much for joining us for today's webinar. So I'd like to introduce some of our VRC staff. So Tammy Morgan and Molly Lozada are actually not present today. Rachel Tanchez is also not present today. We are doing scheduling reminders today, but that will be taken over by Andrea Ogden. And the general questions and CD related questions will be done by myself and Bhumi Parikh. So a few quick notes on continuing education. To qualify for CE, you must attend at least 50 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim CE. And of course, if you have any questions at all, please do email us at cotvrc@facs.org. And since this is our first pre-recorded webinar, CE eligibility will expire on Thursday, August 15th. So if you're watching this for the first time before August 15th, then congratulations, you did it. You must watch the webinar prior to 8:15 in order to be eligible to claim CE. So what is the goal for this webinar? Firstly, to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual, to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. And secondly, to understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patient at your trauma center. So let's get started. So firstly, the Orange Resources book. We always recommend that you have a copy of this handy during these webinars so that you can refer to it as we go through the different questions for this month, either in a hard copy form or PDF, which you can of course find on our website at the resources repository, which is linked at the bottom of the slide. We also ask that you use the most current clarification document and verification changelog in conjunction with the manual. So of course the clarification document and verification changelog, you're familiar with these by this point of course, but they are released monthly. The changelog denotes any criteria, updates, or changes, and the clarification document is any elaborations on existing criteria, and these are also linked on the resources repository, which is linked on the slide. So a few website resources for trauma centers. We go through these pretty much every month, so I'm not going to break them down line by line, but we do have a recording of webinars back through 2016 for you to listen to. The stakeholder public comment website for ongoing changes to existing criteria. We have two tutorials, one on becoming a verified trauma center first steps, and becoming a verified trauma center site visit on the actual site visit process. So we also have the Participant Hub, of course, and the Account Center. We do ask that you go in and add your most current contacts for your facility, your trauma program manager, your trauma medical director, and also your CEO, CNO, whatever administrative contact you would like us to release your final report and other documentation to. And also we have the expanded FAQ, which will break down just additional clarifications on the criteria. So quick disclaimer, all questions are pulled directly from the question submissions. There have been no edits made to the contents. If your question is not answered today, the question may require more information and will receive a response from ACS staff within 1 week after the webinar. So I'm going to turn it over to Andrea Ogden now for some scheduling reminders.
Hi everyone, this is Andrea filling in for Rachel. So first, some reminders about the site visit application. The site visit application is online only, and you can access that on the following ACS Trauma website pages that are hyperlinked on the screen, and those links will also be hyperlinked in the PowerPoint slides if you want to access that directly and then bookmark them. The ACS Trauma website pages will link to the account center page as shown on the screen. And just a reminder that this login is not going to be the same as your PRQ login. It's different. In order to log on, you'll use your username and password that were emailed to you when you started the process of joining a trauma quality program. For example, those who participate in TQIP, this would be the same password you would use to access the TQIP education portal. Once you log on, this will be the first page that you'll see. And on this page, you'll see that you can update your contacts and any facility information. And then for a site visit application, you'll click on the request a site visit as shown on the screen. So you can see that the application drops down and there's a screenshot on the screen. And the online application needs to be submitted at least 13 to 14 months in advance of your requested site visit dates and must be before the expiration date. An alternate pathway review should be requested on the application for surgeons or physicians who trained overseas and want to participate on the trauma call schedule. Their CVs must be submitted to cotvrc@facs.org as they will be vetted by a subcommittee for eligibility to go through the alternate pathway. All Level 1 trauma centers must also complete the Orthopedic Trauma Liaison form, which can be downloaded on the site visit application. And then that form needs to be submitted to cotvrc@facs.org, along with the copy of the OTL's curriculum vitae. We are now accepting applications for 2020 site visits, and 2019 is now closed. All right, so for PRQ online access, once your application has been submitted, the VRC office will provide you with an email receipt to confirm, and then logins to the online PRQ will be provided within 5 to 7 business days, and then these two links that are on the screen that'll also be hyperlinked in the PowerPoint slide deck are very important for you to bookmark or keep track of. All right, site visit application payment. Please do not submit payment until you receive an invoice from us, and you should get that invoice approximately 60 days before your site visit. Your center is going to be billed annually for the trauma quality program fee, and that annual fee will not include any additional visit-related fees such as additional reviewers. But you can access the fee structure on the website that's listed on the screen, and that's helpful if you participate in more than one trauma quality program. Scheduling site visits. Visits are currently being scheduled quarterly. At this time, we are wrapping up the last quarter scheduling for 2019, and we ask that you provide exact dates that you would like the visit scheduled. The visit will occur on your chosen dates, but may ask for different dates should the review team be unavailable on the requested dates. Once the review team has been secured, you'll receive a confirmation email approximately 120 days prior to the scheduled visit. This will include your reviewers and their contact information. All right, site visit preparation in regards to your reviewers. So the ACS travel agent will arrange the site reviewers' flights. Reviewers make travel plans approximately 20 to 30 days prior to the site visit. The hospital will arrange and pay for the site reviewers' hotel accommodations as well as their ground transportation. Please contact the reviewers directly within 30 days of the site visit for their flight itinerary and any logistical information. These are our recommendations to make sure that everyone is set up for a successful site visit. All right, I'm going to pass it back over to Megan.
Hello again, everybody. So before we get into the questions, we do have a few quick announcements. So, the TQIP Annual Scientific Meeting and Training. We have the dates, November 16th through the 18th, 2019, at the Hilton Anatole in Dallas, Texas. Reserve your hotel room now. For more information, go to the TQIP Annual Meeting website at www.facs.org/TQIP meeting. So this is the full list of pre-conference workshops. We encourage you to take a look, just to go through these very quickly. We have the AIS 15 and Injury Scaling Uses and Techniques, and the ATS Trauma Registry course by the Association for the Advancement of Automotive Medicine and ATS respectively. Now, as you are probably aware, as per CD 15.7, these courses do factor into the requirements for registrar training. More specifically, your registrars must attend or have previously attended these two courses within 12 months of being hired, or in the case of the ATS Registrar course, an equivalent provided by your state trauma program. So if this is something that you need to tick off your list before your site visit, this is an opportunity for you to do that. So, skipping down to the Optimal course, Optimal Trauma Center Organization and Management course. This course comes very highly recommended for TMDs, TPMs, and administrators, regardless of whether you're going for your first consultation visit or your third reverification. This course is taught by physicians and nurses with the goal of enhancing trauma center systems of care and improving patient care through implementation of the ACS COT trauma center standards. So this is very much a deep dive into verification criteria, as well as the PRQ, the site visit process, basically everything you need to know to prepare for your on-site review. And then moving on to the topic course, Trauma Outcomes and Performance Improvement course. So this course is very much laser focused onto the performance improvement process and improving the understanding of what makes a good PI process. So it's a very interactive program with a focus on didactic operational definitions, sample tools, case study examples, and take-home points. Now, Optimal and Topic are very much companion pieces to each other, which is why I'm happy to note that this year we are actually offering these courses twice at the conference this year. So do keep that in mind as you are making your conference plans for this year. They're both basically all-day courses. So in the event that you do decide to take them both, you would basically take Optimal one day and Topic the next day. And then, of course, moving down a little bit further, we do, of course, have the Stop the Bleed Basics and Stop the Bleed Instructor courses. And more information can be found at the link at the bottom of the slide.
Hi everyone, it's Andrea again. So we are very, very excited here at the Committee on Trauma to announce a brand new 2-day in-person course that we've been developing for the past few years. It's the Advancing Leadership and Trauma Center Management course, and we're actually launching this just prior to the TQIP meeting. It's going to be a pre-conference workshop. Registration is not open yet, but it will be open in the next few weeks, so keep checking back. You can either check the TQIP meeting website or you can check the Advancing Leadership website directly. We're very, very excited for this course. We have a great group of instructors and a great group of subject matter experts on our subcommittee who are writing the content for this. We have a wide variety of experts from all over the country representing a lot of different areas with a lot of years of experience in different roles. And this is really meant as a multidisciplinary approach to trauma center management. So this course is really appropriate for everyone involved in the management of a trauma center. Your CEO could come, your trauma registrar, your trauma program manager, your trauma medical director, anyone who is or is interested in managing a trauma center. This is a really great course. Like I said, it's going to be a 2-day course in person. There's no textbook per se. There will be a very in-depth resource manual that will provide to all of the students who are coming to the course, and that's going to provide resources, checklists, templates, a lot of resources that you can actually take back to your trauma center and implement right away. So this course is going to not just be didactic lectures, there'll also be a lot of time for question and answers to address your specific concerns or questions at your specific center. There'll also be a lot of case-based and scenario-based discussions that will happen. So we're really, really excited about this course, and I hope that you will go online and check out more information on it. There's an email address as well, and you can just email us. It's altcm@facs.org, and we'll be happy to answer any questions that you might have, and I certainly hope that we'll see some of you in November at this course. Thanks, Megan.
Thank you, Andrea. So one more quick note regarding the next verification Q&A webinar. So for August, that is going to be Wednesday, August 28th. At 1 p.m. Central Time is when that's going to be available. Your deadline to submit questions will be Friday, August 9th. And lastly, we just want you to tell us what you want. We're definitely looking to expand the Q&A structure of these webinars, and that really means reaching out to our viewers and asking what topics you would like us to cover. Reach out to us at cotvrc@facs.org with your suggestions. Future topics may include, but are of course not limited to, discussions of the alternate pathway, specific drill downs into chapters of the Orange Book. And we've covered this before, but we can always go back to it, the peer review process for verification reports. So just let us know what you would be interested in, and we will consider that as we're putting together future webinars. And so just to kick off our first, we're going to call this the You Choose segment. We're going to transition to Bhumi Parikh now for a section on focus by mail.
All right, hi everyone. I will be starting out our first You Choose segment with our focus by mail process. Since we've been seeing an increased number of questions for focus by mail, we wanted to provide a brief segment on how focus by mail works and what documentation is truly required. We wanted to start by describing the difference between focus by mail and focus review on site. So focus review types, whether on site or by mail, are based on the individual criteria regardless of type 1 or type 2, the number cited and or severity. Additionally, any CDs that necessitate a review of medical records requires an on-site focus review. So focus by mail option is only for CDs that can be addressed with submitting documentation, which we will get into. So it is important to note that different CDs will require different types of documentation. For instance, CD 16-15, which is each member of the committee must attend at least 50% of all multidisciplinary trauma peer review committee meetings. For this CD, we would want to see the sign-in sheets for 6 consecutive months after the site visit occurred to see if the committee member is meeting the 50% threshold for what the CD requires. Another common CD that we see cited several times is CD 18-3, which is universal screening for alcohol use must be performed for 80% of injured patients and must be documented. To address this CD, we would like a spreadsheet that shows all your trauma patients, de-identified that is, and then those that received the alcohol screening. There would be a total value that shows the percentage of those that received the alcohol screening, and that should be above 80%. In addition, CD 18-3, which refers to screening, and then CD 18-4, which refers to intervention, are usually cited together. So CD 18-4 specifically refers to level 1 and 2 trauma centers, and that is all patients who have screened positive must receive an intervention by appropriately trained staff, and this intervention must be documented. So to address this CD, we would also like to see a spreadsheet that shows all the trauma patients that screened positive and then all of those patients that received an intervention. So in this case, we would want to see 100% of those patients receiving an intervention. Sometimes centers will do a table and then also provide a graph to show this information. And then it is also important to note that screening and intervention tools can be based on your institution. Some other CDs that we get for focus by mail include CD 8-5. A formal published contingency plan must be in place for times in which a neurosurgeon is encumbered upon the arrival of a neurotrauma case. So to meet the CD, we would like to see an updated contingency plan signed and reviewed by the program administration. Another common CD that we get is for new hires and changes of job descriptions. So for hiring new staff members, for instance, a registrar to comply with CD 15-9, which refers to one full-time equivalent employee dedicated to the registry, must be available to process the data capturing the NTDS dataset for each 500 to 750 admitted patients annually. We would like to see the job description and welcome letter for this instance. For a change of job description, for instance, CD 18-2, which is each trauma center must have someone in a leadership position that has injury prevention as part of his or her job description. For this, a documentation for the CD would include a letter signed by leadership as well as an updated copy of the job description. So another common CD that we get is for boards that have lapsed or a physician or a surgeon not being board certified. So documentation for this can either simply just be board certification document, or if the panel member is removed from the trauma call, then a letter indicating this with signatures by the department director and the TMD would be required. So another question that we commonly get with Focus by Mail is if a cover letter is required. So yes, we would usually prefer your center to provide a cover letter briefly stating how your center corrected the CDs. This letter would be addressed to the VRC chairs and would be signed by the TPM and TMD. Some other common questions that we get are, when is the documentation due and where do I send it? So as a reminder, the corrective action due date is listed on the verification letter that is sent 4 to 6 weeks after the site visit. It will indicate when and where this documentation should be submitted. As a note, the due date will most likely be 1 year from the site visit or the 1 year expiration date, whichever comes first in that case. We also wanted to provide some insight on the process of the Focus by Mail reviews. So once the documentation is sent to the VRC office, we forward that documentation to the original review team. At that point, they may approve the documentation or they may ask for additional documentation. Once it has been approved, the documentation will be sent to the VRC chairs for approval. As soon as all of that is completed, the VRC office will send your center an extended verification letter as well as a new plaque with a new expiration date. So this concludes our first You Choose segment for the VRC monthly Q&A webinar. We hope you like this one. Let's go ahead and get started with the general questions now. So the first question is on ISS admissions. So is ISS score a component of who needs to be admitted to trauma MD? So no, it does not. The ISS should not affect the management of the patient with traumatic injuries. So we have two questions on charts for this month's webinar. So the first question is, charts have always been able to cover more than one category. When did this change? We would have the full chart in one category and a shadow chart in the secondary category. Another question was, practice to date including making a shadow chart with a label notifying reviewers what other category they can find this patient. The nature of the categories required to be presented pulled most likely will result in overlap, such as TBI, SDH, EDH, death, AE, etc. So to clarify, a shadow chart should not be prepared. For best practices, keep the patient chart with the multi-system injuries in what you believe to be the most appropriate category. In the event of a trauma mortality, the most appropriate category would be in death. So the next question is on registry inclusion. Do you place all activated patients into the registry? So to answer this, for best practices, all trauma activations should be captured in the trauma registry. However, what data should be captured in the trauma registry will be based on your institution's inclusion policy. So we have two questions on geriatric care for this month's webinar. Do we have to establish a criteria and/or protocol specific to the care of our geriatric trauma population? The other question is a separate geriatric activation protocol recommended? So to answer this, geriatric-specific criteria and protocol should be present, especially for centers with a large volume of geriatric patients. So once again, this is not a requirement, but it may be cited as an opportunity for improvement for the management of these patients. So also on the VRC website, we have the ACS TQL Geriatric Trauma Management Guidelines that also may be good to review for this. So the next question is on over and under triage. If your treated and released cases ED visits are not collected in the registry, how valid is the over and under triage? So to clarify, the data entered into the trauma registry will be defined by the trauma inclusion policy. If these patients are not captured in the trauma registry, are they being captured separately in an Excel spreadsheet? There should be some kind of process to review and monitor these cases to determine if they should have been a trauma admission. So we have a question on direct admissions. So slide 15 admissions by service does not account for direct admissions. So for verification purposes, the inclusion of direct admits may be reported at the TPM's discretion, either in the PRQ's total admissions by service data table or in the direct admit line. So trauma audit filters. Are there specific registry audit indicators that must be reviewed by the TPM, TMD, peer committee? So, for instance, craniotomy, SCI, etc. So, specific registry audit indicators will vary by institution. However, some audit filter examples may include trauma activations, ED length of stay, over and under triage, washout times for open fractures, and etc. So we have a question on ACGME programs. So for level 1, does the GME program have to be owned by the facility, or can there be an affiliation with another academic program? So if we understand this question correctly, we believe the term GME is meant to be ACGME. So if this is correct, the ACGME program may be in conjunction with or have any affiliation with another academic program. Both programs must be listed on the residency application process. So we have a question on anesthesiologist backups. So for anesthesia response, once you have one patient in the OR with the 24/7 anesthesiologist, do you then need to call in another? In this case, if the anesthesiologists are doing an epi or gallbladder in the middle of the night, the expectation is not to call in a backup. The program should, however, PI this to be sure that the provision of acute surgical care does not lead to a patient not being able to access immediate care. So nursing turnover rate, is this a requirement? So there is not a deficiency related to nursing turnover rate, although there is not a VRC benchmark on the turnover rate for nurses working in the ED and or the ICU. The reviewers will use an average of 20% to cite a weakness, and this is based on the VRC reports that we've seen. So we have two questions on orthopedic injuries for this month. Can you elaborate on the orthopedic criteria regarding definitive repair and application of an external fixator? And another question is skeletal traction or an external fixator not considered a timely definitive ortho procedure if the patient has other issues ongoing preventing orthosurgery within 24 hours? So there are no criteria for external fixator application. The only pertinent criteria is that femur fracture fixation has to happen within 24 hours, and this includes definitive fixation or external fixation. For femur fractures, skeletal traction is not considered definitive, but an external fixator is. So we have a question on trauma activation downgrading. If a trauma is activated but the ED and or surgical PA evaluates the patient before the trauma surgeon arrival and the case can be downgraded, would this still be considered a fallout since it activated the system and the trauma surgeon did not evaluate? Or does outcome play a role, i.e. if discharged, not a fallout, but if transfer or admitted, then a fallout? So yes, this would be a fallout because it was activated and the surgeon did not evaluate the patient. The VRC discourages the use of downgrading. However, there are going to be instances of it occurring. So we definitely understand that this would happen, but in those instances, we ask that it is closely monitored and reviewed through the PIPS process. So it is also important to note, why are things being downgraded? So if trauma activations are continuously being downgraded, there may be some underlying issues with the program or from the field. So downgrading may impact the over and under triage rate, and it certainly can be attributed to the activation criteria. As a requirement, the activation tiers must be continuously evaluated to ensure the appropriate injuries are being captured in the appropriate activation tier. It can also be a system EMS issue where patients are being activated inappropriately, and the most concerning would be that it's occurring so that the attending surgeon does not have to come in. Observations. Can you review examples of 23-hour observation patients that would be included in the PRQ? So for verification purposes, that is, patients that are held for less than 24 hours and discharged would not be included in your PRQ data. But please keep in mind that this may differ from what is captured in your trauma registry. Mortality classification. Is it possible to use unanticipated mortality with OFI as a determination? We have heard this was going away. So there have been no changes to the mortality classifications. They remain as follows. So mortality without OFI, mortality with OFI, and then unanticipated mortality with OFI. Upgrading trauma center levels. So please explain the process from going from a level 1 trauma center to a lesser designation if it's between the 3-year review. Does the center need a visit from the ACS to go to a level 2 or level 3? And this is in reference to a level 1 trauma center. So to clarify, the ACS does not designate but verifies that centers meet the standards set forth for the level it is practicing. The state will designate the trauma center, in some instances, on the outcome of the verification. So to answer this question, it kind of depends on the circumstances. So for example, if currently verified as a level 1 or 2 trauma center and the center lost its neurosurgery capabilities, the center may request to be verified as a level 3. If the center is due for re-verification, it can apply for a different level, and this does require an on-site visit. ICU physician coverage. ICU organization and physician. Can a board-certified surgeon without critical care certification serve as in-house coverage of ICU with help from a PGY4 surgical resident? One surgeon is ABOS certified but is not boarded in critical care. He has been grandfathered by administration to provide critical care and coverage. So yes, this would be acceptable. This is acceptable. Only the surgical director must be boarded in surgical critical care. All other providers in the ICU have to be currently boarded in their respective specialty and credentialed by the hospital to provide care for trauma patients while in the ICU. These providers are not required to be boarded in surgical critical care. So we have a question on webinars for this month's webinar. At times, information in the webinars appears to increase and add to the regulatory requirements of a CD. Are the webinars to be considered an extension of the resources clarification document changelog? When they contradict webinar versus resources manual, which source is to be followed? So without knowing what specific content in past webinars is being referred to, the responses in these webinars are intended to reflect the criteria as they currently exist. Hence, they will be most in line with any revisions made in the VRC changelog and serve as elaborations on existing criteria in the same manner as a clarification document. Massive transfusion protocol. Why does there have to be a physician order to mark MTP as yes? Because during critical situations, when MTP is frequently used, the order rarely gets entered. Therefore, our MTP is being answered no and is lacking. There is no requirement for a physician to mark the MTP order as yes. This may be a registry software tool or a hospital protocol. The only requirement we have on this is that an MTP is developed between the trauma service and the blood bank. Can APPs respond to the highest tier of trauma activations in lieu of the trauma surgeon? So no, that's not acceptable. The APP may be a member of the highest tier of trauma activation team, but cannot respond in lieu or substitute for the, attending surgeon. PTSD screening. Do we need something in place, protocol related to screening patients for PTSD prior and or post-discharge? So no, screening for PTSD is not a requirement. However, it is recommended by the VRC that if your center sees a large number of patients that suffer from PTSD, reviewers may ask how these patients are being managed and whether or not there is a screening tool. On the ACS VRC website, we do have a PTSD checklist and screening tool that can be an example of a screening tool that your center can use. Non-surgical admissions. During our verification visit in February, the lead reviewer provided direction relative to non-surgical admissions that was quite different from the feedback we have received in the past. He indicated that admissions to a medical service were acceptable as long as 1. Timely and appropriate surgical consults were obtained, 2. The injuries were isolated, low-impact mechanism with low suspicion for significant injury. Is ACS changing their stance on non-surgical admissions? Will clearer guidelines be coming? So, to clarify, there have been no changes to the standards. What is noted above is an acceptable practice and is in accordance with what has been stated in recent webinars. Yes, clearer guidelines will be forthcoming. Transfer agreements. If transfer agreements were put in place by previous administrators who are no longer employed, do new ones need to be signed and implemented by current administration before ACS review? So yes, we would like the new administrators to be aware of all transfer agreements. Trauma registrar oversight. So what do the trauma site surveyors look for to ensure appropriate oversight of the trauma registrars by the TPM per page 110 in the Orange Book when the registrars do not report directly to the TPM? If the registrars do not directly report to the TPM, there should be clearer pathways of communication to the TPM to ensure proper data validation for the trauma program. TQL Benchmark Report. What part is our TQL Benchmark Report going to play during future verification site visits? So reviewers are provided a primer, and that is a summary of the hospital's TQL Benchmark Report. We ask that hospitals have their latest TQL report on hand to discuss with reviewers if requested. TQL reports are a good opportunity for hospitals to showcase their PI process, specifically if there are any outliers. This may be an opportunity to discuss how the trauma program plans on addressing these outliers. Hospitals are not being penalized or allotted for their TQIP results alone. Reporting year. When referring to reporting year, does this mean a literal 12 months prior to the ACS survey? I know there's an allowance for a few months to prepare, so would February 2019 to February 2020 be an appropriate reporting year for a June 2020 survey? So our process uses a 12-month period plus a 2-month lag, not to exceed 14 months from time of the visit. For a visit in June 2020, the ideal reporting period would be April 1st, 2019 to March 31st, 2020, or March 1st, 2019 to March 1st, 2020. Over triage. If the trauma surgeon realizes upon arrival to ED for a trauma activation that the case is an over triage, is the expectation that they still complete a full evaluation and document an H&P. The trauma patient should still receive an evaluation and have that information documented in the H&P. Whether the patient should receive a surgical evaluation at that point would be determined by your hospital's guidelines. More importantly, is to look at why the patient came in as an activation. Was this triggered by the EMS? If yes, would this be an opportunity to meet with the EMS and go over your center's activation criteria? Use it as a teaching opportunity. I'm going to turn this over to Megan for the CD-related questions.
Hi everyone, Megan here again for some more targeted CD-related questions. So we have a question on trauma activation response, CD28. When calculating the trauma surgeon response time to highest level trauma activations, do you include traumas that were activated but were not included in the trauma registry, i.e. discharged from the ED or have no injury? Are these included in the 80% requirement for response less than 15 minutes? And this is from a level 2. So, yes, you are definitely going to want to include all of your trauma activations in the total. But more importantly, though, this may be indicative of other potential opportunities for improvement that you'll want to address. You'll want to be looking at your activation criteria and determining whether or not there are trigger points that are causing you to activate in cases where maybe you shouldn't be. And if so, what can be done to rectify that? For example, is this an issue internally with the criteria itself, or is it something at the EMS level? Is this something that in the criteria that you could potentially tweak or provide education on, just to make sure that patients are being activated appropriately? So these are all just things that you should consider as you prepare for your site visit. And here's one on pediatric trauma surgeon coverage. For a level 1 pediatric trauma center, does a pediatric surgery attending have to be in-house 24 hours, or can they take call from home as long as they arrive within 15 minutes of patient arrival? So of course the best method to meet this requirement is going to be by having the attending in-house. However, it would be completely acceptable for the attending to take call from home, just as long as they meet the 15-minute time requirement 80% of the time for the highest tier of activation. And here's one on neurosurgery and orthopedic response. Does there have to be an attending physician to attending physician communication when there is a TCD for ortho and neurosurgery 30-minute response times? Or can a nurse call on behalf of the trauma surgeon to ortho and neurosurgery liaisons and have that call count for the time that 30 minutes starts? So there's actually no requirements on who should call for the specialty consult. So if it's the APP, if it's the nurse, whoever is calling for that specialist, that is the time that will start the clock. So we have another question on neurosurgery response, CD82. Neurosurgery 30-minute response must be at bedside, correct? We're receiving backlash from our neurosurgery residents because they are not always, per them, needed at the bedside if they can review the films, and could we not track by film viewing? My understanding is it is response to bedside. This is from a level 2. So yes, you can definitely forward this response to your neurosurgery residents, but yes, when we are talking about the neurosurgeon's 30-minute response time, we do absolutely mean at bedside. So the neurosurgery resident, fellow, attending, PA, or APP may be the responder for the 30 minutes based on conditions that are defined by your trauma program, but there does have to be clear documentation with the attending neurosurgeon on the patient's plan of care. And here's one on pediatric trained orthopedic surgeons. What is the required number of pediatric trained orthopedic surgeons for a level 1 pediatric trauma program? So as per CDs 1013 and 1015, a level 1 pediatric trauma center has to have 2 board certified or eligible for certification orthopedic surgeons that are credentialed to provide pediatric trauma care, and at least one of whom is pediatric orthopedic surgery fellowship trained. So IR response times. How do facilities track the IR doctor's times if they go directly to radiology and wait for the patient from OR? So in this instance, they would actually self-report the time they arrive at the bedside. So that is how you would track that information. And another one on interventional radiology. Is interventional radiology considered a surgical service? So no, IR is not counted for verification purposes as a surgical service in the same way that microvascular, vascular, ophthalmology, etc. would be counted as a surgical service. So ICU nursing ratio. We are wondering if there is a percentage we need to comply with for the nursing ratio in the ICU. We meet the 2-to-1 ratio most times. So there is a percentage, and it is 100%. Compliance with this requirement must be met at all times. In the instance of an ICU nursing staff shortage, the center must have a plan to acquire more nursing coverage as needed. And here's one on microvascular surgery. What kind of procedures would we need for microvascular if we transfer our reimplantations? Requirement to have subspecialty? So this is from a level 3, and there are actually no microvascular capability requirements for a level 3 trauma center. So that would apply to level 1 and 2, but not level 3. So specialty services, CD 1170 and 1171. What is the opinion about specialty services hand or reimplantation, and whether they should have a backup call schedule? So we don't actually require that you have backup schedules for these specialists, or even really that you have them in-house 24/7. The big thing that we're looking for with this criterion is indication that there is a surgeon consultant available to respond in person, so at bedside, when their expertise is requested by the attending surgeon within a predetermined time. So here's a question on OPPE, CD 1187. Do advanced practice providers in the ED who see patients with injuries but don't meet activation criteria require an OPPE to be done? Or is it only if the ED APP is caring for the patients in the resuscitation bay that they need an OPPE? And this is from a level 1. So yes, regardless of whether or not the trauma patients the APP is seeing met or didn't meet activation criteria, bottom line, if they are seeing trauma patients, you will want to perform an OPPE for them. And as we've said during past webinars, the OPPE for these practitioners would be performed by that APP's respective director. And here's one for mortality reviews. In reference to CD 16.6, do all trauma deaths, surgical service, and NSAs require a TMD review and or a traditional M&M review, secondary or higher? So yes, all trauma-related mortalities must be systematically reviewed, and those mortalities with opportunities for improvement must be identified for peer review. So here's one on alcohol interventions, CD 18.3. Are non-surgical admissions included in the 80% compliance minimum for SBIRT? Is there a required intervention for those who receive a positive screen, or if it's documented that a patient states they don't want any interventions, can this count as compliant due to an attempted intervention? And this is from a level 1. So yes, any trauma patient that's admitted, and this is regardless of the service that they are ultimately admitted to, whether it's the actual trauma service, the orthopedic service, neurosurgery, etc., must receive a screening for alcohol use. And as always, we do want to be clear that this excludes any patients who cannot be considered participatory. Now, if the patient in question refuses any intervention, obviously you can't force them to say yes. So yes, we would still count that as an attempted intervention. You would still be in compliance based on that attempt. And another one on alcohol screening. For SBIRT, we frequently have patients admitted to medicine for a syncopal workup that may have a diagnosis of laceration, concussion, non-surgical injury that in and of itself would not require admissions. Do these patients still need SBIRT? So no. As these are not trauma patients, these would not require evaluation under SBIRT to maintain your compliance. So again, on alcohol interventions, CD 18.4. If a center is not providing interventions to 100% of patients who screen positive for problematic alcohol use, but is reviewing each patient who did not get an intervention through the PI process and is working on a process for universal intervention, would that center still get a deficiency at the time of their review? So this depends. There is some nuance to this answer, I think. So as per CD 18.4, all patients who screen positive for alcohol use must receive an intervention. However, we acknowledge that there can be outliers to this. If there are any outliers that did not receive a screening, there has to be documented PI review for those cases. And this really is going to come down to how many cases this was. If it was limited to only like 1 or 2 cases, it wouldn't necessarily result in a deficiency. But if we're talking a larger number being missed, say 10% or more, this would very likely be cited as a deficiency. And moving on to research publications. Have any revisions been made to the publications requirement for level 1 centers? So I think since more information has been coming out about the chapter revisions, we get a question like this basically every webinar cycle. And unfortunately, our answer is still the same as it typically is. The chapter revision process is still undergoing review. Changes made to this standard or any others will be made available when the next entire edition of the resources manual has been completed, and those changes will be disseminated out as soon as we have more information to provide. And here's a few questions about CME. So starting out with a question on MOC. How do we document that physicians are complying with maintenance of certification requirements? So in order to demonstrate this to your reviewers on site, you're going to want to have a copy of the physician's official MOC participation record demonstrating their current board certification status, and this should be available at the time of review. So is there a continuing education requirement for the Trauma Process Improvement Coordinator? And I think we get a PI coordinator question basically every webinar now as well. But to clarify, no, we don't actually have any education requirements for the Trauma PI coordinator. If a surgeon is only taking backup trauma call, are the CME requirements and multidisciplinary trauma peer review attendance of 50% still required? So regarding the CME leg of this question, it is important to note that the CME requirement is only going to apply to a non-boarded surgeon that is undergoing the alternate pathway, that is, non-boarded and non-eligible for certification. That said, all surgeons that are taking trauma call, whether they are backup call, locum tenens we get a lot of questions about, they still must attend at least 50% of the multidisciplinary peer review meetings. And we did mention the alternate pathway in the last slide, so we do have a question about that here as well. We have several orthopedic surgeons undergoing the alternate pathway, non-US boarded. Our verification visit is approximately 1 year away. Do they need to have all 36 hours of trauma-related CME by that visit? So for a first-time verification, this is going to be prorated for all practitioners, so a minimum of 12 hours of CME, so that's 1 year's worth of CME counted towards the requirement, must be present for any new surgeons that are undergoing the alternate pathway process. And again, on the alternate pathway, regarding orthopedic surgeons undergoing the alternate pathway, does attendance at our trauma peer meeting count towards their 36 hours of a required CME? So no, unfortunately, the trauma peer meeting would not count towards their CME requirements. You would not be able to cite that to remain in compliance. And since we do tend to get a decent number of CME-related questions for these webinars, we just kind of wanted to do a quick breakdown of what the current expectations are, who this is required for, how many hours of CME they're required to have over what extent of time. And so to clarify, CME and CE, there are requirements for the TMD, the TPM, and any alternate pathway surgeons. New trauma centers, as we said before, that are undergoing verification for the first time, their CMEs would in that case be prorated to 12 hours or 1 year's worth of CME. Any new members to the trauma panel, this is along the same lines, CMEs may also be prorated to 12 hours. The exception in this case will be based on the hire date, so there is a bit of nuance to that exception. Any surgeons that are undergoing review through the alternate pathway, their CMEs may be prorated to 12 hours. The TMD is required to have 36 hours of CME within a 3-year period. It doesn't have to be 12 per year exactly, but it should at the end of that 3-year period add up to 36. Any surgeon who previously was approved by way of the alternate pathway is required to have 36 hours of CME within 3 years. And the TPM is required to have 36 hours of CE within 3 years. We do have a table here as well that breaks down which practitioners require CME and which practitioners will meet it through board eligibility, lifetime boards, or board certification, or MOC. So you can see under meet CME requirement, emergency medicine physician, orthopedic surgeon, neurosurgeon, critical care. All these people on the left will meet the CME requirement through board eligibility or board certification or MOC participation. The people that we are going to be looking for to have 36 hours of external CME, trauma-related, would be the TMD or pediatric TMD, alternate pathway surgeons, and the trauma program manager, meaning CE instead of CME in this case, of course. And one more quick note regarding lifetime boards and how you are going to reflect that in your pre-review questionnaire, since we have seen this come up a little bit here and there. So when it comes to surgeons that have lifetime boards, when you're completing your online PRQ appendices, you're going to want to list the board expiration date as indefinite for those surgeons who have lifetime boards or are grandfathered in. So just something to keep in mind as you are preparing your PRQ for your site visit. And that's all we have for today. Thank you so much for your participation and hope to see you next month.
All right, thank you trauma verification staff, and thank you everyone for attending today's webinar, Trauma Verification's July Q&A web conference. If you do have any other questions, please email us at cotvrc@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today and have a great rest of your day.